Meet Sheila. She's a 58-year-old teacher living in Alberta. In 2020, she started experiencing hip pain, which her doctor dismissed it as menopause. She tried cortisone medications, exercise, and physiotherapy, but nothing seemed to work. The pain got so bad that she had to leave her job and stop doing daily activities that she once enjoyed, such as teaching and even playing with her grandchildren. She finally got to see a specialist for surgery and for severe osteoarthritis, but the surgical wait times were close to 2 years. The system forced her to seek out private surgical options, and she had to pay over $40,000. Sheila's not alone in this problem, and Alberta surgical wait times is making headlines across Alberta. This is Disjointed. As a family medicine resident doctor, I see firsthand the impact of surgical wait times on patients' quality of life. Throughout this presentation, we'll see systemic issues facing Alberta hip and knee surgical wait times, and we'll present ways to improve and redesign the system to improve for patients like Sheila and many others. We'll also present ways and key insights that we learned through our journey on MAPS system as well. Before we dive into the topic, let's go over some terms. Osteoarthritis, or OA, is the breakdown of cartilage over time causing pain. The gold standard to treat this unmanaged pain is through surgery, and surgical wait times is the time from doctor referral to the time of surgery, and the national benchmark in Canada to complete 90% of the hip and knee surgeries is 26 weeks. As you can see from the chart here, Canada falls well below this standard, and Alberta's even lower this standard as well, making it one of the worst provinces in the entire country. And in the 80s and 90s, surgical wait times continued to grow, and in 2005, Alberta piloted a project for centralized intake and coordinated care to improve surgical wait times and slashed it by 80%. However, this success was not failed to come across the entire system at this time. And then in 2020, Alberta had to go towards private surgical delivery to increase the capacity as well. But that drove up costs and decreased the quality of surgery as well. And even recently, the Alberta Health Services CEO left due to profit operators and causing further distrust within the system. Alberta surgical wait times for hip and knee surgery might seem small, but it's representative of greater fractures within the Canadian healthcare system, including the primary healthcare crisis, privatizing healthcare, and the eroding distrust. And we want to improve equitable access to healthcare for Sheila and many, many others. And Alberta surgical hip and knee wait times is like a canary in the coal mine, representing larger systemic issues, which highlights our first key insight. And to research our system, we took numerous approaches, including a variety of interviews and scanning through many research modalities, analyzing data, and creating system tools to help with that as well. And we want to thank many of our contributors, including patients, doctors, administration, and other allied members who all helped us on this journey.
Thanks, Cap. Through all of our interviews and all of our research, we were really looking for one number. How big of a problem is this really? And unfortunately, we weren't able to find that anywhere. So we did it ourselves. We did our own economic modeling to come up with three important numbers. We estimated the economic loss, the quality adjusted life year loss, and the social sentiment loss. All of these really illustrating how big of a problem this is. So we're happy to get into these inputs a little bit more in Q&A. But we wanted to talk about how we actually came up with our system map in the first place. This is where we started. This is our big giant systems map, and it incorporates every stakeholder, interaction, product, and byproduct currently existing in the system. We took this map and then we turned it into this, which is our interactive systems map, which represents a little bit more about the nuances within the system, specifically taking a look at reinforcement loops. I'll talk about the branches a little bit more in a moment, but for now I'd like to take a second and talk about the core. This is really how we derived our ideas. broken up into three parts. Demand, how many osteoarthritis surgeries are needed? Supply, how many effectively can we give? And then triage, how well can we match our demand and our supply, taking into account any financial, political, and geographic constraints? This drove us to our next key insight. Solving root causes is a key thing that we've seen a lot in terms of recent policy, but it doesn't work because of something called perpetuating factors. Root causes, I'll talk about them a little bit more in a moment, but we really think that our key insight here was in order to drive effective change, we need to address the perpetuating factors. So now I'll dive a little bit deeper into our first root cause, which is increasing osteoarthritis incidence. Why? Two reasons. Alberta's population is aging, and Alberta's population is becoming increasingly inactive. What's this perpetuated by? It's the idea of poor medical management. And within poor medical management, why currently osteoarthritis always goes to surgery. And that doesn't need to be why it is. Why? Because currently family care doctors are not required to treat osteoarthritis, and they're also so busy that they're not able to in the first place. Our next root cause on the supply side takes a look at constrained resources. This exists in three capacities: workforce, infrastructure, and then also private care delivery. And it's important to account that workforce doesn't just apply to surgeons, but also anesthetists and nurses and administrative staff all across the healthcare system. This is perpetuated by the idea of poor surgical efficiency. Why is there poor surgical efficiency? Essentially, we have trouble getting, with scheduling in terms of getting patients actually into the OR, and then turnover, which refers to the idea of getting them out. Underscoring all of this is the idea of triage, where poor overall ability to find data causes us to have an inability to triage, and then once we have the data, there's currently no system in place to deal with it from that perspective. I'll pass it off to Howard now to take over the solutions.
Now, we have also looked into three other systems map. Now, one thing for sure is that we are looking into user journey process map, which uncovered that triage is a bottleneck in the waitlisting process. The iceberg model, particularly on the medical models, patients and also surgeons are thinking that surgery is beyond medical management, which is of the market perpetuating factor. Next, on the stakeholder and power interest map, we have seen incentive misalignment in the private care delivery system, which drove post-surgical efficiency. And this is our third key insight. Different lenses uncover new dimensions in our broader systems map. Now, onto our solutions landscape, we have analyzed provincial, national, global, and even other disciplines in terms of solutions, but all of them seem to address and assume that constrained resources is the only problem. And there's three more gaps in the solutions. One, misaligned incentives, they did not address that, minimal preventative care, and underutilization of technology, which we have mapped onto our systems map, categorized into service delivery, funding, and technology. And there's 12 of them in our system map, and correspondingly, for each one of them, we have an intervention. And in the next 3 slides, we have 5 in the demand side, 5 on the supply side, and 2 in the triage side. We'll not bore you down with the details. Let's focus on what's important here. What drives the greatest impact, and how has the highest visibility. And this is the result of talking to frontline medical staff who thinks that staggered approach will drive effective impact, which is our fourth key insight. Now, onto the supply side, let me talk you through the top 3 solutions that we are proposing. In the current system, private clinics are not paid and contracted by complexity and outcomes of cases. And we have seen data that they are cherry-picking easy cases as a result. So what if we tie the incentive to the complexity and outcomes of cases that will solve and promote quality of care? Next, on the demand side, we are proposing to set up community clinics for assessment and management. And this is because we have found that there is a gap in the experience curve between the general practitioners and the surgeons and the specialists. So having a middle step, someone trained staff who could be the middle step towards the specialists, will reduce strain on this system. And lastly, we need to standardize and have comprehensive intake forms so that we could triage by urgency level and risk level. So what do we learn? We have 4 key insights throughout this presentation, and that leads us to the call to action.
So 3 main calls to action. Number 1, we need to stop funding system firefighting and start funding system design. Number 2, we need to lead the approach from a reactive to proactive approach of care. And then ultimately, the public and you needs to feel comfortable advocating for change.
Many people think that patients fall through the cracks, but Sheila didn't fall through the cracks. She was navigating a system that was disjointed by design. It's time to fix the system.